All right, we are recording now. Okay, so this is going to be part B. However, this presentation is going to be identified as Chapter 13, Endocrine System, Part 4. Okay, this will be identified as Part 4. So we're going to dive in and focus on something that is probably of interest to the thyroid gland. It is the butterfly-shaped gland, right? And it has the isthmus, which is the median mass connecting the two lateral lobes. So it's kind of a butterfly. It has two lobes on it. So let's take a look at let's just take a look at it first, and then we can come back and take a look at some of these things. So we look at the thyroid gland and we're kind of figure out where are we, right? Well, look, here's the aorta, right? Up here is the epiglottis. This is the trachea. Oh, this kind of looks like, I know, it may not look like a butterfly so much, but yeah, this is the gross anatomy of the thyroid glands. It's very important. And what they were trying to say is this, the isthmus of the thyroid is kind of in the middle. If you were to draw a little line, that's what that is. This would then be, this is assuming that an individual is in the classical anatomical position looking toward you. So therefore, this would be the left subclavian artery. Where am I? No, I'm sorry, left, yeah. And as a result, this is going to be the left lobe of the thyroid. And as a result, this is going to be the right lobe of the thyroid here. So make sure we keep our orientations. All right. One of the things that I wanted to mention here is that the colloid, which is it's the fluid of the follicular lumen containing the thyroglobin plus iodine. So it's very important. Where is that? Let's see. Well, iodine is a major component of this. So it is a precursor to forming the thyroid hormone. Now, calcitonin, we've gone over it in part 2, I think a little bit of part 3, maybe not in part 3, but it's a part 2. The parafollicular cells, these are the ones that are going to be producing some calcitonin. Now we look here, it's a little bit of the histology, looking at this. This is where kind of we take a look, and I'm going to try to look into the PAL and see if they do provide some good histology area on the endocrine system. I think they would. So the parafollicular cells, they're going to be the ones right here. These are the ones that are going to be producing the calcitonin. This here is the fluid that I was kind of discussing with you earlier. So this around here, we have this colloid filled follicles, and we have that. It's kind of filled in there. Now here's what we really want to get into. The thyroid hormone, it's a player. I mean, it's pretty darn important. And it's one of the body's major metabolic hormones. And that is one of the reasons where let's take it step by step here. We talk about what is metabolism. That is catabolic and anabolic reactions. Well, when you say metabolic hormone, that means that it could be involved in the making or breaking of things, but it is utilizing ATP energy to do stuff. When you're not using different forms of energy, well, then we have to conserve them in the form of usually adipose tissue or other forms, mainly adipose tissue, fat. So as was asked in the other section that we had was, hey, well, can this potentially if this is off, can it affect my overall workout if I keep working out and I'm not seeing results, and I've been trying, I go to trainers, I try. Yeah, it could be, because it is one of the body's major metabolic hormones. Now, it is found, thyroid hormone, there are two kinds. Two kinds. And it's found, they're the T4, T3. Now, they're very easy to remember. And why? Well, because the thyroxine, it's a major form that consists of two tyrosine molecules with 4 iodine atoms. Got it. Okay, so notice how the iodine is then coming into play. Now, the T3, in this particular case, we're going to have 2 tyrosines with 3 iodine atoms. Now, it says here, must be converted to T4 at the tissue level. So as a result, these hormones, these are thyroid hormones, T4, T3. They are both iodine-containing amine hormones, or amine, however you want to pronounce it. So iodine is important, and that's how come we can use a radioactive iodine to help situations with the thyroid, because this is where iodine is going to bind your T4, T3. And that's very important knowledge. Now, again, as I started out, I'm like, oh, thyroid hormone, it's a big one. It's really involved. So it says here, affects virtually every cell in the body. Yeah, that's how come it's so important to make sure that we have a good, healthy thyroid. Monitor that. Now, it enters target cells and binds to intracellular receptors within the nucleus. And if it's going to be binding with the intracellular receptors within the nucleus, you can bet that it's going to be doing something with some form of genes, right? So it's going to be inducing transcription. What are some other things that it can do? Well, it can you can have increased basal metabolic rates. Meaning, well, if this hormone's producing, and you got quite a bit of this thyroid hormone, that's whichever you want, it can increase your metabolism. And if you decrease this thyroid hormone, it could decrease your metabolism. Where did you get that? It says metabolic rates, meaning the rates of making and breaking things within the body. That is metabolism. Catabolism plus anabolism equals metabolism. Well, when you are making and you are breaking things, and energy is going to be released, it is not 100% captured, and as a result, heat is produced. This here, metabolic rates and heat production is referred to as the calorigenic effect, like calories. Other things that TH can do, thyroid hormone, is regulate tissue growth and development. Not like GH, similar, but not quite. Critical for normal skeletal nervous systems development. Now that's involving nervous systems and reproductive capabilities. Thyroid hormone, very important for blood pressure. Now remember, blood pressure, right, has a lot to do with the vasodiameters, meaning what is the internal diameter? Are we constricting? Are we dilating? What the heck is happening here? So we have increased adrenergic receptors in blood vessels. All right, let's talk a little bit about its synthesis. Well, the thyroid gland stores hormones extracellularly in the follicular lumen, which means extracellularly, set outside cell of the follicular lumen, until it is triggered by this TSH to release it. Now there's 7 steps that go through this thing, and we'll take a look at these steps, right? We will take a look at these. But one of the things I want to talk about real quickly is I want to give some props to this here. I need to make sure that we grasp that iodine is trapped. So iodine is an ion. What is an ion? It is a charge. It's charged. It's charged. So it has a negative charge. They're actively taken into the cell and released into the lumen. Now, when iodine begins to become oxidized, the electrons are removed, converting it to iodine, to iodine molecules that are bonded together. So what I want to show you now is go through this here. You have to remember where we are in this picture. This is literally, you have your thyroid follicular cells. And we are, and this is the colloid, and we are like right here. And this is going to be one of the capillaries. All right. So let's just take it back. This would be like if we were somewhere here, something like that. And then if you want this is the colloid, this is the follicular cells, right? But we don't see the artery. It's not there yet. This would just be a cross section of the thyroid. We don't see that artery there. It would be kind of cool if we showed it. So that is where we are. Okay, so what I'm going to do is I'm going to pass these. They're going to talk about it. Now, we have to go back and get a little bit of information in terms of some cell biology to kind of get this. So here we have the endoplasmic reticulum. In particular, there's going to be the rough endoplasmic reticulum, the ribosomes, and we have our Golgi apparatus. The Golgi apparatus, you have to remember these functions of these two. What are they going to be doing? This is going to be the cis and the trans, and this is going to have this is like the UPS or United States Post Office. It's going to be packing, shipping, reorganizing. It's going to move over here, and then we're going to have some fusing because of its structure here. It can fuse because likes dissolve likes. Keep that concept always in mind. So when you reach this part here, it's able to fuse in and dispense whatever the modifications took place. So what we have here is the capillary and iodine. Where in the heck in the world are you going to get this freaking iodine from? Well, the iodine is going to come from various sources of foods, not naturally fortified, added. If you ever go to the store and you look and you see salt and it says this is iodized, non-iodized salt, it's because one contains iodine, the other doesn't contain it. And the FDA, Food Drug Administration, has approved the adding of iodine. We'll get later into what are some of the situations when we don't have iodine, when you have small amounts or very little of it. Looking at this situation here, the thyroid globulin is synthesized and discharged into the follicular lumen. Okay, we have that. Now, what we have here is in step 2, iodine is trapped, actively transported in. Now it's actively, it kind of binds here and then it fuses along this cell membrane. And when it fuses, you have this degradation and push or degradation of this transport, and the release of iodine is then trapped and moves across this channel, moving here into this area. Now, what happened here is you have part of the thyroid globulin molecule. It's kind of like in here, it gets modified, packed, and shipped. And because of this, again, similar characteristics here, it gets fuses across, and now you're here. So you have this piece, which is very important. It's the iodine is going to then attach to the tyrosines of the thyroid globulin molecule, right? So you have thyroid globulin is synthesized and discharged into the follicular lumen. Great, you got this going on here, but hey, look what's coming on the other side. You got tyrosines. So what happens is the iodine that came in from the bloodstream capillary area here came in over here, passed through the receptor, the channel here. You have iodine here, then you have the tyrosines, and you have DIT, MIT, which then come back in the thyroid globulin colloid. And as it comes back into here, you're going to have the creation. So ionated tyrosines are linked together to form T3 and T4s, right? Because that's the way we have them. So here is an example of a T4, because 1, 2, 3, 4 iodines, and T3, 1, 2, 3s. And it's going to create this vesicle right here. And it's going to have that penocytosis. It's going to kind of get pinched off, cell eating, cell drinking right here. And the thyroid globulin colloid is endocytosed or endocytosis and combined with a lysosome. It gets combined with a lysosome. So the lysosome can then have a degradation of it. So lysosomes enzymes then are going to cleave the T4 and T3 from the thyroglobulin and hormones diffuse into the cell. So what is cleave? It means to break. It's going to break it. So you have this come in, then this combines with the lysosome, and the lysosome is going to cleave and break. And then as a result, these go back into the bloodstream. And now you have the productions of your T4 and your T3 going back into peripheral tissues. Again, T4, T3 transported by the thyroxine binding globulins. What else do I want to say here? Peripheral tissues has enzyme needed to convert. Yeah, enzymes remove. Yep. Now, in terms of homeostasis, the thyroid hormone is released and regulated by negative feedback. So decreasing levels of thyroid hormone is going to then have some sort of positive feedback that's then going to cause thyroid stimulating hormone. This right here, this TSH. Well, rising levels of thyroid hormone or concentrations, I prefer to use concentrations, they're going to provide a negative feedback. So therefore, an inhibition of the thyroid stimulating hormone. So this thyroid stimulating hormone, right, it's going to stimulate this. But if you have high levels, you want to inhibit this because you're already, that's too much. Like you're already done. Like that's enough. Well, also the thyroid stimulating hormone can be used to inhibit GHIH, which we just talked about, some dopamine and increased levels of cortical and iodine. Now, what about the hypothalamic thyrotropin releasing hormones? This comes back again into negative feedback, and it can overcome it. It can overcome negative feedback during pregnancies or exposure to cold, or especially in infants. These are just some little tips here. Now, going back and trying to understand feedback, regulation, homeostasis, and this is where it really, where the key is, and you have to get this part because it starts with the hypothalamus, right? Hypothalamus going to the anterior pituitary, from the anterior pituitary, we're going into the thyroid gland, because it's this guy, this one up here that's going to be producing the thyroid stimulating hormone, TSH, right? So you want this. You want this to increase if you're going to want your thyroid to produce thyroid hormones, i.e. T4, T3. But if you come in here and you block this, then that's good. Then you would do that in the case that you have enough of these hormones. So you have quite a bit of this, T4, T3, and then you're going to say, okay, your body's going to say, all right, we need to go negative feedback now. So you're going to go and you can come in here and you're going to say anterior pituitary, hey, let's slow production of TSH. And as a result, which is the thyroid stimulating hormones, we're going to then reduce this, and the thyroid's not going to produce as much T4 and T3. Same thing with hypothalamus. If you can reduce this up here, you can cause a causal chain to decrease, therefore decreasing thyroid hormones. So keep that path in mind. In terms of hyposecretion of TH in adults, right? So that means that we are having low levels of T4, T3, lead to myxedema. So what happens is you're going to get into the low metabolic rates. And that's what I'm trying to tell you that. And the question that was asked, hey, can the thyroid be affecting my overall workout situation? I'm really trying here, really trying. I'm working, I'm dieting. Yeah, it can. It can't be. I'm not saying it is, but it is a potential target. You may want to look into that. Why? Because if you're going hypo, you're going to go low metabolic rates. That means you're not going to be building as much muscle. You're not going to be using as much energy. You're going to be storing more fat than you might think, right? Now, here are some other things that when hyposecretion of TH can induce, and these are some very important things: dry skin, puffy eyes, feeling chilled, constipation, edema. They're not being specific, meaning swelling, mental sluggishness, lost thought. Hey, as I told you before, I used the word lethargic. Here they're using the word lethargy. So these are some of the signs of an individual who may be going hypo in terms of the thyroid. Now, if, and this is a big if, they should make it a very big if, it is very difficult in the United States of America to have a lack of iodine. But if you do, goiter may develop. I've never witnessed it. I've never seen goiter in my life. I've only seen pictures of it, but it is possible. So a lack of iodine decreases thyroid levels. I don't thyroid hormone levels. I don't know about that. A lack of iodine decreases the thyroid hormone level. I honestly don't. I don't fully agree. Well, we just went through this. It is not that iodine is decreasing T4, T3, which is thyroid hormones. No, it's not that it's decreasing it and that it's serving as some sort of, as far as I know, some sort of negative feedback inhibition. It is that it is one of the building blocks of it. Right? That's what I thought. Here, thyroxine, triiodothyronine, it has iodine. It's bonded. That's what the molecule is. It consists of two tyrosine molecules with 4 iodine atoms. This one here, 2 tyrosine molecules with 3. That's what this is. That's what thyroid hormone is. It's found in 2 forms. So it's not that the iodine is inhibiting anything. It's that it's part of its design. And if you don't have iodine, you don't have T4, T3. So that's very unusual. But nonetheless, and the thyroid can enlarge. Now we go back and we talked about how this does have impacts in development. So it is crucial, it's important for normal growth, and we said neurological brain development in early childhood is very important. It is possible where an individual develops a poor thyroid. It can happen. It's kind of a it just can't happen, and as a result, it can do several things, like pituitary problems or maternal medications may sometimes really affect the baby's ability to make TH. You can find yourself where maybe you have asymptomatic or present in weak cry, poor feeding, constipation, prolonged jaundice. However, it says TH replacement is crucial and is usually lifelong. That's what we just said before we ended this. And those who are watching may not understand like what we're talking about. It's that I stopped the video in terms of saving time for loading up. But we did talk about a question in terms of having low GH, which is growth hormone, and that individuals can go on treatments for that. And we're kind of talking about TH now as well, where you can get on certain hormonal replacements, but it's usually a long life thing. Let's talk and it kind of jumps. So the thyroid disorders, right? And this is going to be goiter, right? Goiter. And due to lack of iodine. Again, very rare. I'm sure it does happen, but it's a very rare situation. It doesn't say that's rare, but I'm telling you, trust me, it is rare. Now, this one is going to be more likely Graves' disease. This has nothing to do with anything that you eat. This is hypersecretion of TH, most common type. They call it Graves' disease. This is an autoimmune disease where the body makes abnormal antibodies directed against the thyroid follicular cells. And as a result, these antibodies, I know it's so crazy, these antibodies mimic the thyroid stimulating hormone. They mimic it. And as a result, since they mimic it, guess what? Bam, what? You look like this? Hey, let's produce thyroid hormones. Let's produce some of that T4, T3. We got that TS. No, it's not. It's not your normal TS. It's an autoimmune disease. Don't fall for the trick. Don't fall for the trick, thyroid. They're antibodies. They're mimicking TSH. And then the thyroid's like, hey, what's up, TH? It's not TH, antibodies. And then now you have this TH, and then you have thyroid release. A lot of it being released. And boy, let me tell you, that person starts cleaning the house, they start cleaning the blinds, they start mopping the floors, they start reading all their chapters, and they go crazy excited. Metabolic rate increases, they probably start sweating, start talking fast like me right now, irregular heartbeats, nervousness, they're kind of like tweaking, kind of like, oh, what do I do, what do I do, what do I do? And you can have some weight loss because metabolic rates are increasing super fast right now, and then usually results later in a crash. So that's usually the way it goes down. And as a result, this is the severe case. This is the severe, this is once it's going on for a while. Let me show you. That can happen. That's not normal, right? So you would probably want to be like, hey, yo, my eyes something's wrong with me. I should probably go see a doctor somewhere. And yes, and you can get this situation under control. So let's never take it to this level. That's just a little, why would you do that, right? Why would you not get treatment for that before that happens? It does happen. What are some situations that we can do in terms of in the hypersecretion situation? Well, I already told you about the radioactive iodine because of the T3 and the T4, and we just showed you that whole scheme, how it goes, how iodine has the affinity for T3 and the T4, and it makes that. So let's put a little bit of radioactivity up on that iodine. It's not going to go anywhere else in the body. It's not going to connect to anything. It's not going to harm anything else because of its affinity and specificity. So it's a wonderful, wonderful treatment to use the radioactive iodine to help destroy some of those cells. And why? Well, they could be also leading to a tumor, things of that nature. Treatments could also remove, but removal will most likely be because of cancer. That would be some of its removals. Do we have any questions, ladies and gentlemen?
No, sir.
So, like the crash, and it was asking, what's the crash like? The crash is physically tired. That's the second part. This is usually a crash and results in just exhaustion. The person's not just running around doing all that stuff anymore, and usually results in a crash. That's the type, and not painful from my understanding of it, but just exhaustion. So those are some of the things that can happen in terms of some of the diseases. Yes.
Is that Graves' disease? Is that like what you were talking about with your friend? And then she ended up having the tumor. She was like really hyper and all this energy, and then would crash. And she went and got checked out and had the tumor. Is that similar?
Exactly. She did that, but she didn't get to the point of the eye bulging.
That's good.
Yeah, like we would hope, right? That like, hey, it's time to go to the doctor. So like I said, that usually is gonna have to take some time, like going untreated. But no, she didn't come to me with her eyes bulging like that.
That happened to my friend, but it only happened on one eye.
Wow.
So like you could really tell. And he had to go and get surgery on Monterrey. And yeah, that's all.
And that was the thyroid, right?
Yes,
Yeah.
that was that.
Okay.
It was only on one eye. I don't know why, but it only happened to him on one eye.
Yeah. What, did he go to Monterrey Tech?
Like, did he study there?
No, like to the doctors there. Like, yeah.
Yes, to the doctors there. Yes. Yeah.
Okay. All right. Thanks for sharing that. Yeah. Thanks. So yeah, you don't want to get to that point. You don't want to get to that point of the bulging eye parts. You can probably figure out something's not going well. But again, knowledge is important, right? Like so much, like what we do now, us as a group, now we see things and we're like, boom, boom, hey, the red flags, right? We get it. But the average person could be like, hey, my eye is kind of getting larger, bulging. It could be allergies. Could be in their minds, it could be allergies. But for us, you're going to be like, whoa, hey, buddy, I covered my endocrine system and I covered it really, really well. And let me tell you, I don't know what that disease is called. Let me look it up really quick. Oh yeah, that's called Graves' disease. Hey, there's probably something up with the thyroid. Let's make sure you check out with meet up with an endocrinologist. So what seems to us as what's going to seem to you and I as common knowledge of understanding is not common knowledge. How many people around you in your home, in your community, your neighborhood are taking A&P 1 and 2, right? Very few. So as a result, you are going to understand certain things that other people may not. And this is where you become very important to help others. So yeah, but this is a very important topic. So we have a student right now who's already testimonies saying, yeah, hey, look, these things do happen. Very interesting that it was a male. I think she said male. Was it a male?
Yes.
Wow.
It was a male, and he's really young. He's like 20. So I don't know what he didn't tell me like in detail like what he do and stuff, but you could tell it was only on one eye. And I don't know, I thought that was like, because when you showed us the picture, it was both of them. And yeah, I thought it was interesting that it was only on one of the eyes.
And the surgery is probably removal. It could have been one lobe. Hopefully it was just on one lobe, a left or right, right? So he can still continue to produce TH, right? I hope it wasn't a full removal, because if it was full removal, then as we just discussed, then that individual would have to go on TH replacement for life. And that can be a tough thing. And the cost, it's expensive. So right here could include surgical removal of Graves, as we just chatted. Let's talk about a little bit about some calcitonin. We mentioned that way earlier on. So it is the parafollicular cells that are in response to high calcium levels. So the antagonist to parathyroid hormone, PTH. So this is the antagonist. Now, it says no known physiological role in humans at normal physiological levels, but at higher than normal levels, high concentrations, right? Because remember what we're talking about, calcium levels at high concentrations, it inhibits the osteoclast, right? That goes back to the skeletal muscle part, a skeletal system. We start looking into bone marrow, we start getting into all that kind of stuff. And we then see, okay, inhibits osteoclast activity and prevents the release of calcium from the bone matrix. Well, so this will then stimulate CA uptake and the incorporation into bone matrix. So calcitonin. Parathyroid gland, I guess, keeping with this parathyroid hormone, moving into parathyroid gland. It says 4 to 8 tiny yellow brown glands embedded in the posterior aspect of the thyroid. So it says 4 to 8. Typically there are 4. Let's take a look at what this means. This is what we're talking about. Within the thyroid, right? These here are parathyroid. I've heard of individuals with 3. I have never heard of 2. I've heard of 3. I'm sure there are some cases out there, but typically 4. I have not heard any, like, known anyone with 8, but hey, maybe. So the parathyroids are going to secrete parathyroid hormone. And parathyroid hormone is most important hormone in calcium homeostasis. Well, that's going to be pretty darn important. Calcium, my Lord, the different things calcium is involved in. We can go on and on. So if this is what's going to be secreting parathyroid hormone, and this hormone is important because it's the balance of calcium, so therefore secretes in response to low blood levels of calcium. So if you have low blood levels, your parathyroid hormones are going to be produced by your parathyroid glands. Notice how this here has an effect way, 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 way far from the point of origin. The parathyroid glands also get negative feedback inhibition once there is enough calcium ion channels. Where are these? Where is this parathyroid going? Where are the target organs? What's going to be the skeleton? Most, like a lot of it's going to go to the skeletal system and some kidneys and intestines. Parathyroid glands. Well, we're in the same topic. Functions. Again, stimulate osteoclasts to digest bone matrix. And during the digestion of bone matrix, we will release the calcium into the blood, right? Well, also, if you're going to be doing this, parathyroid gland also functions to enhance the reabsorption of calcium and secretion of phosphates by kidneys. Promotes activation of vitamin D by kidneys, which leads to the increased absorption of calcium by intestinal mucosa. Ladies and gentlemen, again, you can have all the calcium in the world. If you do not have vitamin D, game over. You are not going to absorb that. This is very important for those of you who are going to be working with people of the age of 65 and up, specifically females. Why? Well, osteoporosis. We just talked about osteoclast. So now we're going to get into osteoporosis. So we need to make sure that, yes, these individuals have calcium, but you must have vitamin D for the bioabsorption of calcium. And that,
Sir,
yes.
isn't that what helps like make the bones stronger.
Yeah. Yes.
So, and isn't that why females are more prone to when they fall, like broken hips and stuff like that?
Yeah. After a certain age, senior citizens more broken to it. And it also goes back again, right, to hormone, a change in hormones. And what hormone are we talking about? Parathyroid hormones. They're going to be producing, usually at an older age, they're going to be producing less. Therefore, there's going to be less calcium because that's going to release calcium into it outwards for do many multiple functions. So as a result, you need an older person needs to take calcium and vitamin D so the vitamin D can help in the absorption of calcium. A lot of people think like, I'm just going to take calcium for me, strong bones. Like, yes, that's great, but you need to take vitamin D. So just always think you need to take a C and D, right? And just C's and D's go together. And you need to have that. If not, there is no point. There is no point. Same thing with having all the vitamin D in the world. Great. But if you're not supplementing with calcium, not going to work out. So keep those two things in mind. And that is part of the field of pharmacology, toxicology. When some of you take your pharmacology, you're going to get into bioabsorption and you're going to understand those concepts. So like, I think it was us, not sure, we talked about vitamins, that the trick to having vitamins help you is bioabsorption. So just keep those things in mind. So we take a look quick here. This is a good one here. Hypo mean low, calcemia, calcium, low calcium in blood. What's going to happen? Hey, these parathyroid glands are going to release PTH. This is what we want, right? So we come over here and we can have osteoclast activity in bone causes what? Calcium and the phosphate release into blood, right? Because look down here, blood. What else can we have here? We mentioned kidneys. So if there's an increase of calcium, you have reabsorption in the kidney tubules. That's going to get into blood. What about over here? We have activation of vitamin D by kidneys. Hey, we're going to have some absorption of calcium from food and small intestines going on here, right? And then we can get in blood. Now, of course, once this happens, we don't see it here. It's not shown, but let me tell you, we come back and we have all these negative feedback inhibitions to say, hey, parathyroid, these little parathyroid guys, slow it down. We got enough. That does happen. Again, just in following the same concepts of hyperthyroidism, the same concepts apply with hyperparathyroidism. And it's largely due to a tumor on the parathyroid gland, which is resulting, these tumors, you have to understand what it is, the cells, and these cells, they're replicating, they're dividing, they're decreasing in number, and if they're decreasing in numbers, they're going to increase in parathyroid hormone. Well, if that's going to happen, boy, so calcium's going to leach out from bones, causing them to become softened and deformed because it's releasing. And then here, elevated calcium depresses. Remember we talked about how calcium how it's important in the nervous system? Then depresses the nervous system and contributes to the formation of kidney stones. Yeah. So watch that out. Watch for that too, right? Someone with kidney stones. They keep having kidney stones and they're of like a younger age. Why? We're great at taking kidney stones out. That's not a problem. But why is the person keep forming kidney stones? There has to be a reason. It just doesn't happen. So there we need to start thinking, whoa, hey, wait a minute. We're having quite a bit of release of calcium because this is forming in the kidneys. This person came in, we took out these huge stones. They're back 2 years later, right? Hey, red flag, throw the red flag. Something's happening here. Could it be hyperparathyroidism? Hey, you better do check that blood and let's make sure we double check it. While we're at it, hey, Maybe this person, let's just knock it out. Let's get a little MRI of that thyroid gland. Let's take a quick look-see at the parathyroid. Why not? So keep those things in mind. Now, since this is being released, broken down, it can cause fractures or ease in fractures. So you have this younger person, right? We just talked about a person younger in his 20s who had Graves' disease. You have this younger person, pretty eats healthy, he's kind of active, and then he or she's involved in sports. And then let's say it's a situation where this person's been involved in sports since high school, and when they go into high school, but then junior year they break a bone, break an arm. Then they break a finger in football practice. They're in volleyball, then they break some part of their wrist. They're in basketball, and some bones keep breaking. Red flag. It's most likely not accidents or sheer bad luck. It means most likely that there is a situation occurring that's resulting in releasing of too much calcium from bone, therefore resulting in less density, and therefore making the bone more likely to be fractured. So keep that in mind. Weak bones, right? So a lot of times these things just, especially young people, they're young, right? So they look at a young person like, oh, he's just a string of bad luck. Or he's a young person and they'll just say, he's healthy. He just, he'll walk it off and get back to put him in a cast, and Eric will just go back into the game. Later, 6 months from now, that breaks another bone. Something's going on. He could potentially have some form of a tumor on the parathyroid gland. And you are not going to feel that. You're not going to feel that. First of all, these glands are super tiny. So they're tiny little tumors. Super tiny. You're not going to feel a lump. It's not one of those type. So you're going to go on. And you're not going to feel that. Just like my friend who had a tumor for who knows how long. So keep those clinical situations in mind. Hypo. Now, following gland trauma, right? Something happening, right? It's different situation. We're not talking hyper. There's maybe damage to it. Something has some sort of trauma. There also could be some removal. There could be, if you remove, if you remove, you remove half of this and you only have 2 parathyroid glands, and now you're down to 50% production, right? It doesn't take a mathematician to realize that. So then you can get into hypocalcemia. And it could result in multiple things. It can get bad. It can get real bad if no one intervenes and tries to bring the hormone back to balance. So adrenal gland. This one is gonna be also very, very, very important. Very important. Let me look at something real quick. Let's do a stop share. Halfway. Yeah. Well, ladies and gentlemen, I think I have to tap out. My voice is going. I don't know if you hear it, but I've been talking for quite a while today. And I don't have any water or anything to drink. I think that's another one. So I'd love to continue on this nice chat, but I do have to tap out at this point. So I'll stop the recording, and we are going to leave it off right here at the adrenal cortex. Okay, that's midpoint of the presentation. That's slide 68, and that is where we're going to come back. Slide 68. So I'll stop the recording on this one.